Welcome to our hypertension review. In this video, we will master the classification of blood pressure, causes of primary and secondary hypertension, the diagnostic approach, cardiovascular risk assessment, lifestyle modifications, and how to choose the first-line drug classes based on patient comorbidities. Let's get started. Hypertension is defined by the ACCH 2017 guidelines using 4 categories. Normal is systolic below 120 and diastolic below 80 millimeters of mercury. Elevated is systolic 120 to 129 and diastolic below 80. Stage 1 hypertension is systolic 130 to 139 or diastolic 80 to 89. Stage 2 hypertension is systolic 140 or higher or diastolic 90 or higher. Step 2 Pearl. Whichever number is higher, systolic or diastolic, determines the stage. Always confirm a hypertension diagnosis with repeat measurements on at least 2 separate visits. Hypertension is classified into 2 main types based on cause. Primary hypertension, also called essential hypertension, accounts for about 90 to 95% of cases. It has no single identifiable cause and results from a mix of genetics and environment. It usually appears between ages 30 and 55. Modifiable risk factors include obesity, high salt intake, alcohol, and sedentary lifestyle. Secondary hypertension accounts for about 5 to 10% of cases. It has an identifiable underlying cause and may be curable if the cause is treated. Suspect secondary hypertension when the presentation is atypical or red flags are present. Step 2 Pearl. Most hypertension is primary, but always consider secondary causes in patients with resistant hypertension, young onset, or sudden severe hypertension. Secondary causes of hypertension fall into 4 categories. First, renal causes. These include renovascular hypertension from renal artery stenosis, chronic kidney disease, glomerular disease, and polycystic kidney disease. Second, endocrine causes. Primary hyperaldosteronism, also known as Conn's syndrome, pheochromocytoma, Cushing syndrome, thyroid disorders, and hyperparathyroidism. Third, vascular and structural causes, coarctation of the aorta, and obstructive sleep apnea. Fourth, drugs and substances, NSAIDs, glucocorticoids, oral contraceptives, decongestants, stimulants, alcohol, and cocaine. Step 2 Pearl. Always take a thorough medication and substance history in every hypertensive patient. Simple removal of an offending drug can normalize blood pressure. When should you screen for secondary hypertension? Look for these red flags. First, age less than 30 at diagnosis. Second, resistant hypertension, meaning blood pressure remains uncontrolled despite 3 or more drugs, one of which must be a diuretic. Third, sudden or accelerated hypertension. Fourth, malignant hypertension with end organ damage. Fifth, clinical clues that suggest a specific cause, such as episodic headaches, palpitations, and sweating, which point to pheochromocytoma. Step 2 Pearl. A young patient with resistant hypertension and hypokalemia should make you think primary hyperaldosteronism. Screen with the aldosterone to renin ratio. Hypertension is often called the silent killer because it is usually asymptomatic. Most patients are diagnosed incidentally or through screening. Symptoms typically appear only when end organ damage has developed. 4 main systems are affected. Cardiovascular damage includes left ventricular hypertrophy, coronary artery disease, heart failure, and atrial fibrillation. Cerebrovascular damage includes ischemic stroke, hemorrhagic stroke, and transient ischemic attacks. Renal damage includes chronic kidney disease, proteinuria, and hypertensive nephrosclerosis. Ophthalmologic and vascular damage includes hypertensive retinopathy, peripheral artery disease, and aortic aneurysm or dissection. Step 2 Pearl. Because hypertension is silent, regular screening and early treatment are essential to prevent irreversible end organ damage. There are 3 main ways to measure blood pressure for diagnosis. First, office blood pressure. This is the standard initial method. Diagnosis requires confirmation on 2 or more separate visits, using the average of 2 or more readings. Measure both arms on the first visit. Second, Ambulatory blood pressure monitoring, or ABPM. This is the gold standard. It uses a 24-hour monitor to detect white coat hypertension and masked hypertension. Third, home blood pressure monitoring, or HBPM. Patients measure their own blood pressure at home. It is a cost-effective alternative to ABPM and useful for confirming the diagnosis and assessing treatment response. Two important patterns to remember. White coat hypertension is high in the office, but normal outside. Masked hypertension is normal in the office, but high outside. Step 2 Pearl. Before diagnosing hypertension based on office readings alone, confirm with ABPM or HBPM to rule out the white coat effect. The SCVD 10-year risk score guides treatment decisions in stage 1 hypertension, meaning systolic 130 to 139 or diastolic 80 to 89. Start pharmacologic therapy in stage 1 hypertension if any of the following are present. First, an SCVD 10-year risk of 10% or higher. Second, existing clinical cardiovascular disease, such as coronary artery disease, stroke, peripheral artery disease, or heart failure. Third, diabetes mellitus. Fourth, chronic kidney disease. Step 2 Pearl. Stage 1 hypertension with a low SCVD risk, below 10%, is treated with lifestyle changes first. Stage 2 hypertension always warrants pharmacologic therapy from the start. Lifestyle modifications are essential in every hypertensive patient and can be as effective as a single drug. First, weight loss. This is the most effective single lifestyle intervention. Roughly 1 millimeter of mercury drop in systolic pressure for each kilogram of weight lost in overweight individuals. Target a body mass index under 25. Second, the DASH diet. High in fruits, vegetables, and whole grains, low in saturated fat, can reduce systolic pressure by about 11 millimeters of mercury. Third, sodium restriction. Aim for less than 1,500 milligrams per day ideally, or less than 2,300 as an acceptable goal. This reduces systolic pressure by about 5 to 6 millimeters of mercury. Fourth, exercise and alcohol moderation. Aerobic exercise 90 to 150 minutes per week. Limit alcohol to 2 drinks per day for men and 1 for women. And of course, smoking cessation. Step 2 Pearl. Combining multiple lifestyle changes can lower blood pressure by more than 20 millimeters of mercury, often as effective as a single antihypertensive drug. There are 4 first-line classes of antihypertensive drugs, all equally effective for uncomplicated hypertension. First, ACE inhibitors, like lisinopril and enalapril. They block angiotensin II formation, preferred in patients with diabetes, chronic kidney disease, or heart failure. Common side effects are cough and hyperkalemia. Second, ARB, such as losartan and valsartan. They block the angiotensin II type 1 receptor, a good alternative when ACE inhibitors are not tolerated, because they do not cause cough. Third, calcium channel blockers, particularly the dihydropyridines like amlodipine and nifedipine, preferred in Black patients and elderly patients. Fourth, thiazide diuretics, such as hydrochlorothiazide and chlorthalidone, also preferred in Black patients. Common side effects are hypokalemia and hyperuricemia. Step 2 Pearl. Beta blockers are not first line for uncomplicated hypertension. Use them only when there is a compelling indication, like coronary artery disease, heart failure, or atrial fibrillation. Antihypertensive choice should be tailored to comorbidities. In diabetes mellitus, ACE inhibitors or ARB are preferred because they are nephroprotective. In chronic kidney disease, ACE inhibitors or ARB are preferred because they reduce proteinuria. In heart failure with reduced ejection fraction, the standard combination is an ACE inhibitor or ARB plus a beta blocker plus a diuretic, with spironolactone added in severe disease, after a myocardial infarction, or in coronary artery disease. The preferred combination is a beta blocker plus an ACE inhibitor or ARB, which reduces mortality. In Black patients without other compelling indications, calcium channel blockers or thiazide diuretics are preferred over ACE inhibitors, as they generally respond better. In elderly patients with isolated systolic hypertension, calcium channel blockers or thiazide diuretics are preferred. Start low. Go slow. Step 2 Pearl. Combining an ACE inhibitor with an ARB is contraindicated because it markedly increases the risk of hyperkalemia and acute kidney injury.